Welcome everyone. This is our third episode of the series with Arizona Law and the Working Group on Compassionate Use and Pre-Approval Access, also known as CUPA, at the NYU Grossman School of Medicine in the Division of Medical Ethics. And today's topic will be covering real-world evidence from expanded access during COVID. I am Tara Sklar. I'm a professor of health law and director of the Health Law Policy Program at Arizona Law. We started this series over the summer because of the many legal, ethical, and policy issues that were emerging in what seemed to be the most dramatic way seemingly possible during this pandemic. And what makes this third episode particularly special is we partnered with the American Society for Law, Medicine, and Ethics because they are an organization dedicated to bringing our health law community together in virtual sessions such as these types of webinars to cover critical topics that we all care about and want to learn more from, especially from a range of different disciplines and perspectives. We have two earlier episodes that are still quite relevant to what's happening right now, and they're available for you to watch, and we'll circulate links to them after this webinar. The first was on vaccines and possible therapies for COVID, including development of and access to. The second webinar focused on caring for non-COVID patients during COVID. What we try to do in each of these webinars is bring together the widest range of representatives from clinicians, academics, patients, and patient advocates in both the US and abroad. And I think this session today absolutely does that. We have the pleasure of having Dr. Michael Joyner join us, who from the Mayo Clinic and also a proud Arizona alumnus. And he is leading the largest expanded access program in US history. And then along with that, we have a panel of experts from the US and abroad who will be talking about expanded access, which has seemed to become a household phrase, along with convalescent plasma, emergency use authorization, and other therapies and regulatory terms that no one had really heard of prior to this pandemic, which is actually part of the reason at Arizona Law that we are engaged in these types of webinars and exercises. We are really interested in building the collective knowledge base around unproven therapies in terms of safety and efficacy, but in some cases could be a person's only hope to a possible treatment that could work. Related to these discussions that COVID's heightened are also issues around fairness and the ability to access these types of investigational therapies from across population groups, including those who are at disproportionate higher risk. Together with CUPA, we have worked with a course that we offer every summer now with the amazing Dr. Allison Bateman House, which is called Access to Investigational Products, Clinical Trials, Expanded Access, and Right to Try, which addresses all of these issues and many others. We really strongly encourage patients and patient advocates to take part in this course. We are happy to mitigate any barriers to cost or otherwise to make sure it's accessible as possible for anyone who's interested. And we also plan to keep offering webinars. We have our next one planned for December 4th. It's a Friday. It will be episode 4. The topic and further details coming out shortly. And I hope you'll be able to join us. So with that, I'd like to now introduce Ted Hutchinson. He is the Executive Director with the American Society for Law, Medicine, and Ethics. And then I'll turn it over to Haley Bailey, who is the Assistant Professor in the Division of Biostatistics and Co-Chair of the Ethics and Real World Evidence Project of CUPA at the NYU Grossman School of Medicine. So thank you and enjoy.
Hi, I'm Ted Hutchinson, Executive Director of the American Society of Law, Medicine, and Ethics. On behalf of everyone at ASLME, welcome to this webinar. At ASLME, we always work to bring scholars in different disciplines together to discuss the most important issues of the day. We've done that this summer through multiple webinars, through our conferences, through co-hosting the Public Health and the Law Conference, and we'll continue to do it this spring and into the coming year with our co-hosting of the 6th Annual International Conference on Law Enforcement and Public Health and our own Health Law Professors Conference. And we continue to work with different scholars every day in our two journals, the American Journal of Law and Medicine and the Journal of Law, Medicine, and Ethics. So we invite all of you to become a member of ASLME. In the meantime, welcome to this webinar, Perspectives on Real-World Data and Evidence Collection through Expanded Access during COVID-19. We thank our co-sponsors, NYU Health, and especially the Health Law and Policy Program at at the University of Arizona College of Law. Thank you for attending this webinar, and thanks especially to all of our speakers and panelists today. I hope you have a great webinar. Thank you for joining us.
Hello, my name is Haley Belli, and welcome to today's webinar. The format for today will begin with a presentation by Michael Joyner, who is the Frank R. and Sherry K. Wood Professor of Anesthesiology at the Mayo Clinic and Principal Investigator of the Expanded Access Convalescent Plasma Program for the treatment of patients with COVID-19. During Dr. Joyner's presentation, please submit your questions via the Q&A feature at the bottom of the screen. The remainder of the webinar will be a panel discussion during which we will field your questions. It will be moderated by Tom Watson, Executive Vice President for Early Access Programs at Bionicle EMAS, and my fellow co-chair of Coupa's Ethics and Real-World Evidence Project. Our panelists include Claudia Hirwat, Owner and Executive Chair of VOZ Advisors, and Holly Fernandez-Lynch, the John Russell Dixon, MD, Presidential Assistant Professor of Medical Ethics at the University of Pennsylvania. All three of these individuals are Coupa members. And finally, both Dr. Joyner and I will join this panel. And on that note, I'll turn the mic over to Dr. Joyner.
Thank you so much for that wonderful introduction. And Professor Sklar, Professor Belli, again, thanks. And we will just get started with this interesting story. So I'm going to talk a little bit today about convalescent plasma for COVID-19 disease. Because this is BARDA funded, I have to show this disclaimer. And again, really the bottom line is the bottom line, and it's that assumptions made within and interpretations from the analysis are not reflective of the position of any U.S. government entity. So what is convalescent plasma? It relies on the principles of passive immunity. Typically in a pandemic situation, it's sort of the first best shot on biological goal. It's simply the transfer of antibodies from a recovering patient or animal, and it can be used as post-exposure to prevent disease, in other words, in a prophylactic setting. It can be used to treat disease, and it's got really a long history. And in fact, the first Nobel Prize in medicine around 1900 was given to Emil von Behring for use of passive immunity principles to treat diphtheria. So the conceptual model is extremely straightforward. In this case, we'll use COVID-19 as an example. You have a patient. The patient recovers, blood is drawn, there are virus neutralizing antibodies in that blood, and either the plasma or serum, which is a subset of the plasma, is removed and either given to prevent disease after an exposure or given in a therapeutic modality to treat disease. Now this has a very long history. Here's some data from 1918, and this is convalescent blood products for Spanish influenza. And they thought it might be a treatment down the road because people were worried in 2006 when this paper was published about future Spanish-like pandemics. And the bottom line here, again, is that you can see that about 16% of people, or 54 out of 336, who were treated with convalescent plasma products died versus 37%, or 452 out of 1279. Now, this is not in any way reflective of a modern randomized clinical trial approach. But if you actually go back and read these papers, and I've looked at some of them, they're actually ingenious, advanced, and show how creative and really on the money scientific investigation was 100 years ago. Now, how did I know about this, and what's my trip into the expanded access program wishing well, I guess. I was down in Atlanta at the United States Olympic Trials Marathon giving a talk about human performance, my normal area of scientific expertise. And my friend Arturo Casavidal published this op-ed in the Wall Street Journal about the use of convalescent blood products to stop an outbreak of measles, because Arturo thought that the main use for convalescent plasma products would be prevention. Well, it turns out Arturo is a good friend of mine, and we communicate regularly. And I emailed him back and said, you know, Arturo, this could be done at scale. The blood banking infrastructure in the United States is huge. About 30 to 40,000 units of blood products are collected per day. So again, I felt we had the blood banking infrastructure to do this. Beyond that, I knew nothing about convalescent plasma, nothing about passive immunity. And in general, I try to stay, or at least until February 28th, tried to stay about as far away from infectious disease as I can. So by mid-March, a network had self-assembled of our friends behind Arturo and myself around the idea of convalescent plasma. A lot of us knew each other as a result of a shared concerns about excessive reductionism in biomedical research. The folks at Hopkins generated a prophylactic protocol to give this to healthcare workers who'd been exposed. We simply adapted their program for early use in the hospital. In late March, there was lots of interest nationally. The FDA begins to announce EINDs for compassionate use. Houston Methodist and New York Mount Sinai use it, and this is March 28th. The blood bankers start to get mobilized. Demand for EINDs begins to overwhelm the FDA. If you talk to Dr. Peter Marks, who's the head of CBER, and Dr. Nicole Verdun, his deputy, one of his principal deputies, they were getting 50, 60, 100 or more EIND requests per day. And if you looked on Facebook or other social media, there almost was a black market developing for have you recovered? Can you donate plasma? Can you get it to my relative? So the expanded access program was developed by Dr. Marks for two reasons. One is to stop the need for hundreds of EINDs per day, and also to try to coherently capture some data on what was happening. So the timeline is pretty straightforward. Peter contacted me late one night on the 30th of March. I immediately contacted our IRB chair, Dr. Scott Wright, and asked if he could be a part of it, if Mayo could be the central IRB. Scott said yes immediately. We approved the IRB and agreed to serve as the central IRB with reliance agreements for other places. People didn't have a lot to do because the hospital was shut down. So our website people got busy and rolled out a generic website, which gave us site, MD, and patient enrollment forms, workflows. We had navigator and FAQ functions, case report tools, and we developed a full service communication center, which included email, phone, and other things. The first patient was transfused on the 7th. The last enrollment occurred at the very end of August. So I think that's about 5 months. We had about a 5-month run here, which is of interest. Really, our charge was straightforward: provide broad access to COVID-19 convalescent plasma, perform a robust safety analysis, and more recently, we've been attempting to explore efficacy. Now, access was really an important thing, and this is a picture of Chaim Leibovitz, who's a member of the Orthodox Jewish community in New York City. They were hit early, they were hit hard, and Chaim is a friend with a man named Shmuel Shoham, a physician at Hopkins, who takes care of many Orthodox community members in the East. And Shmuel said to Chaim simply, you guys should all go donate and the supply would go way up. So people like Chaim, who's in the shoe business, a wholesaler, has tremendous logistical and business skills. He worked closely with the blood collectors, the New York Blood Center and others in the Northeast, to really streamline their logistics, get people signed up, get people qualified, enhance donations. The other really important patient group was Survivor Corps, led by Diana Barrett, who's done some great work as well. So really, this became almost a textbook example of community engagement and how interactions with community leaders like Chaim and Diana really made a difference. Fantastic people. So what's happened since then? Well, when enrollment closed, we had about 2,800 hospitals throughout the U.S. who'd signed up. I want to point out that the vast majority of these places had never done a randomized clinical trial and would never be able to do one in any traditional sense of the word. There are 6,200 hospitals in the U.S. We had, again, almost 2,800, 14,500 physicians, over 105,000 patients. And this number, as we've gotten more records in and reconciled this gap, is now up to about 86,000 total patients transfused, far greater than the original IRB cap of 5,000. So we expected to just really take the burden off the FDA, get some safety data, and do sort of some medical records research at the end of this year and early next year. But obviously things got out in front of us and really took off in ways that none of us could have imagined. So how did this happen? Well, Arturo obviously had the idea. My main contribution was it could be done at scale. The FDA saw the need for the expanded access program. Why they pinged me, I'm not sure. Apparently, somebody at the NIH, I think Jim Kiley, who's head of the a division chair, a branch chair at the NHLBI, told them that I had a history of being able to get things done. Dr. Scott Wright is really an interesting guy because he had attempted to set up sort of a really futuristic trials network about 15 years ago that just never quite took off. And it was really sort of a classic false fail. And he really helped us use some of the concepts he'd developed over the years to use in the EAP. Doctors Delisa Fairweather and Caitlin Bruno were basic scientists who'd been doing some questionnaire-based research on people with myocarditis, and they had become expert with REDCap and set up all our forms on REDCap. Dr. Ricky Carter, a statistician I'd worked with before, was able to set up sort of rapid real-time data analysis techniques. Our lab developed novel assays that could be done at great scale, and we have a big reference lab at Mayo, so we were able to bring samples in from all over the country. The really interesting thing is the fellows, the junior clinicians, and the analytics staff, so people who really hadn't been, had their creativity turned off by too much education or too much experience, really stepped up and identified problems and solutions versus, this is the way we've always done it. We are lucky enough, we have a strong administrative and compliance staff. Some of that I helped build when I was a vice dean for clinical research 15 years ago. So we had people who could deal with the FDA and so forth. Our institutional leadership was supportive. BARDA came through with funds, and then we had, for the things the government couldn't handle, like getting people coffee and food in the middle of the night and on weekends. Those are unallowables. Philanthropic dollars and other resources were available. So the current status is we have an emergency use authorization as of late August. There are many ongoing randomized control trials, different places. And I think it's really important to avoid the EAP versus RCT false dichotomy, and I'm sure we'll be able to get into that later. And again, let's just think about the epistemology of this and the climb to establishing efficacy. So there's all sorts of historical precedents for passive immunity. Antibody mechanisms of action are well known. A number of case series observations specific to COVID-19 occurred very early in the disease, as early as January. Convalescent plasma is therapeutic in animal models. We have case series with matched controls, and we've now got some efficacy data from 35,000 patients in the trial that's up on our preprint server. So that's it for me, and I'm happy to take any questions.
So Mike, thank you so much
Yes.
for a short but really interesting presentation. So I certainly can't think of a time in history when I guess the subject of access to investigational drugs was more topical or relevant than today. I have a couple of clarification questions for you, Mike.
Please do.
And then I'll give you a breather and go to the panel. So the first one, just to clarify the patient numbers, obviously we are talking, large patient numbers for an expanded access program, but you talked about 105,000 enrolled, only 78,000 infused. So was that because the EUA kicked in before those guys were infused?
No, there's always been a gap, Tom, and if we know about 6,000 people or 7,000 people for whatever reasons either died before, especially early on when there was a lot of rescue or salvage therapy in the ICU, may have died before they had the opportunity to get convalescent plasma. We know people declined some for other reasons later on, or there were logistical issues. We think that roughly 90% of people consented got plasma. But as we got into that second wave, one thing we noticed in the first wave in April, May, when it was primarily in the Northeast, many of those hospitals had shut down. So the research nurses and study coordinators could be repurposed to help the clinicians do the case report forms. And many of those places were more academically flavored. As things diffused out and we got into the second wave, the hospitals were overwhelmed. So we've had one large hospital system that was, thousands of records late or slow. And we're just working with everybody to curate the data, find out what's going on, and to just continue to understand, where that missing data is. But I think when it's all said and done, we'll have 6,000 or 8,000 people that were or maybe more, that weren't transfused for one reason or another. And somewhere around 90%, 85, 90% of these people have been transfused. That's just a guess, but it's been good so far.
Got it. Thanks, Mike. So I guess you predicted a question, or you must have had 1,000 questions, and you termed this the false dichotomy between RCTs and EAP. So it'd be good for you to clarify exactly what you mean by that false dichotomy in the first instance, and then from that, Mike, we're going to have questions that say, what were the efforts put in to transition this EAP, given the scale, to a randomized controlled clinical trial?
Well, I think a couple things, Tom, is first that, of these nearly 2,800 places, the vast majority of these places don't have the skills, the infrastructure, and so forth to do trials. Not that they couldn't, but it would take a lot of training and capacity building. Which is something to think about down the road, because we did have about almost 20% African Americans, and about 35-40% of our patients were Hispanic. So some of those sites could be really ideal for later capacity building. So what happened is, as this got going, remember, we had an uncharacterized product given at a guesstimate dose to all comers. But what became clear, I think, by June 1st, roughly, is that the timing of transfusion mattered. You probably wanted to get higher titer or convalescent plasma with more antibodies, and again, you needed to get it quickly, and by then the supply problem had largely gone away, because the blood collectors working with Diana and Haim and others had really upped their game. So I think what should have happened is, and we suggested this, we said, Dr. Wright, myself, Dr. Carter, other people in our group suggested it to various places in the U.S. government, that, for example, the CTSA site should have been peeled off of the EAP, and there are 60 of those at the big academic centers. Part of the CTSA program, Tom, is to have this sort of trials capability available, and they could have been trialized there. And I think we would know better, but we would have had enough information to design a coherent trial. One of the things that is in a fast-moving story like this is that a trial designed April 1st may have been, we're going to try it in the ICU. Well, one thing I think everybody's shown, and we saw it yesterday with the remdesivir data in the New England Journal, that rescue therapy is very challenging. That we're going to continue to see early is better, which is not unusual for infectious diseases, or really any time you deal with life-threatening disease. So to me, the false dichotomy is, well, you guys enrolled 105,000 patients, thereby destroying any opportunity for randomized trials. When the real story is that EAP was completely appropriate for a variety of reasons. It grew dramatically because of the synergies I showed in the numbered slide. And the question then is, why weren't the academic sites peeled off and trialized?
Yeah,
we certainly suggested it.
Yeah, and to your point, there's separate work that we'll undertake to try to take the learnings for future.
Yeah, no, and that's the key point. There, since 2000, Tom, we've had anthrax, Ebola a couple times, Zika, SARS, MERS, H1N1. People were concerned about. So this is at least the 7th big one in the last 20 years. So hopefully, when we're ready the next time, we'll understand that.
Thanks, Mike. So I'm going to give you a break for a few moments, Mike.
Great.
But on that,
Thank you.
I guarantee that there are going to be questions, and we're going to come back to you
on
that last topic. I know you will. I'm going to switch gears slightly, and this is primarily a data-driven or data-focused webinar. So, Haley, I'm going to come to you first, if that's okay, and focus primarily on the relationship between sample size, because this was obviously of a magnitude that we've rarely seen, if ever seen before, in expanded access. So what I'd like to understand is the relationship between, I guess, statistical significance and validity of data and sample size, and in particular, what evidence we can draw from observational data, of this magnitude.
Yeah, absolutely. So in this case, we have somewhere between 75,000, 85,000 individuals. And that data is extremely powerful for learning, especially about safety information, adverse events. Of course, in the case without a control arm and in the absence of randomization, which are key features that allow us to draw causal inference in a clinical trial, it is challenging to determine the exact magnitude of a treatment effect. However, this real world data certainly can and is presently informing the design of clinical trials that can determine if convalescent plasma is actually safe and effective for the treatment of COVID-19. And so examples of how it could do that is identifying potential subpopulations that may benefit most from the therapy and dosing, depending on patterns that we're seeing in this data. And in terms of clinical trials actually being underway, which was mentioned, I want to bring attention to one project in particular, especially since Dr. Joyner mentioned that some sites just might not have the resources to run clinical trials because they're expensive, they're very time intensive, they require a lot of research staff. So a current project underway, it's PI'd by Andrea Troxel at NYU, who's an expert in pragmatic clinical trial design. And it's literally called the Compile Project. So it's basically taking all of these smaller convalescent plasma trials underway. And they have sites from Brazil, the Netherlands, Spain, and then in the US of many areas from the greater New York to Miami, Texas, San Francisco, and Philadelphia. So at the end of the day, basically what's going to happen is definitely we're going to take those trial results, compare them to the same outcomes in this real world data collection that we have through the EA program, and do a side-by-side and look at basically which different elements and the study designs and where bias may or may not be introduced in these various studies, and pool them together into a meta-analysis.
Thanks, Haley. Gives us a good insight, Haley, into some of the things we can be doing, particularly with the data of that size. So I can turn to you now, Holly, if possible. So clearly there are a number of ways in which patients can access COVID-19 investigational drugs. It would be good to understand those different pathways, the relationship between those pathways and their capacity, ability to generate rigorous data, if you can.
Sure. Yeah. Thank you. And thanks for that talk, Dr. Joyner. So, you know, the most obvious way that patients gain access to investigational drugs is through clinical trials, right? That's kind of the standard pathway. And we know that trials can be designed well or poorly. We've seen lots of poorly designed trials in the context of COVID-19 with, you know, small groups of patients, observation only, lots of interventions at once, not being kind of careful about what participants or patients are receiving. But when trials are well designed and done well, they have the best capacity to provide meaningful insight into safety and effectiveness, because as Dr. Belli was talking about just a moment ago, they allow for control groups and randomization and blinding. And those things are really critical for a disease like COVID-19, which we know affects patients really differently, with some patients spontaneously getting better, some dying, some, you know, experiencing these long-term outcomes, right? So it's kind of difficult in a disease like that when people get better to know, was it because of the intervention that they received, or would they have gotten better on their own, right? And that's what a control group can help you understand. Now, another option that we were just hearing about for accessing investigational products is expanded access. And this is a regulatory pathway that is intended only to be an option when patients are unable to enroll in clinical trials. That's actually one of the regulatory criteria for expanded access. You have to be a patient that has a serious or immediately life-threatening disease or condition. It has to be the case that you've exhausted your standard options, and that the benefits of you getting this investigational product outside of a trial outweigh the risks. But really the key criterion is that you cannot get the drug that you want through a trial that you are eligible for. Expanded access can be provided to single patients, right? We heard that there were hundreds of single patient requests to FDA at the beginning of this process, and then they can transition all the way up to large groups. We've seen historically a large group in the Mayo expanded access protocol for convalescent plasma. And large groups can be fine in expanded access so long as they won't interfere with running clinical trials. And that can be true, for example, when large-scale expanded access is provided after a phase 3 trial is finished and FDA is considering a marketing application, right? You generally don't have concerns there because there aren't other trials going on. FDA is just kind of analyzing the data at that point. but it's important to be careful about a couple of things. So one is making sure that patients who really could participate in a trial are not allowed to secure expanded access just through loose interpretation of the rules, right? That they aren't permitted to just kind of opt out from a trial because they'd rather not be randomized. And then the other thing to be careful about is making sure that when expanded access launches in the first instance, because there aren't a lot of trials going on, that the program doesn't get so large as to inhibit those trials from taking off, right? To kind of create this impression that, well, you know, patients are getting access, we're going to focus on other things rather than trials. And I think that's a really circular problem, or a catch-22. I worry that's a bit of what we saw with convalescent plasma, where a really large expanded access program with broad inclusion criteria might have made it difficult for trials to launch, even once it became clear that there were lots of patients and clinicians who were interested in this approach, right? And so this is the catch-22 part. If it's hard to get trials going, then that feeds into allowing the expanded access protocol to get bigger and bigger with more patients who can't get in trials because there aren't trials for them to enroll in, right? So, you know, we don't know, right, whether more sites would have been willing to step up and launch trials if they didn't have the expanded access protocol to fall back on. And we heard from Dr. Joyner that, you know, there were suggestions to that effect. I'd love to hear more about, you know, why those suggestions weren't taken up. And then, you know, as Dr. Belli was saying, we can learn from expanded access protocols, especially about safety, but they have their limitations. Now, what happened with convalescent plasma is it transitioned to this third pathway by which patients can gain access to investigational products, and that's the emergency use authorization. And I purposefully am still calling it an investigational product because an emergency use authorization is different from traditional FDA marketing approval, where FDA has applied these rigorous standards of demonstrated safety and effectiveness. The EUA standard is much lower. It's a legal bar of just the product may be effective. And the EUA, unlike expanded access, does not necessarily include any protection for trials, right? There's no requirement in the EUA law that you have to first be able to get a product through a trial, and only if you can't be in a trial can you get a drug through emergency use authorization. FDA can, by its discretion, add that type of protection in for an EUA. In the context of COVID, they've only done that for hydroxychloroquine, but it didn't really matter there because that drug was available for off-label use. So it didn't matter that FDA said, this is only an EUA for folks who can't get hydroxychloroquine in a trial, right? So typically, once an EUA has been issued, any eligible patient can access that drug absent supply challenges, right? Regardless of ongoing trials. And so the worry that you might have is that if you issue an EUA prematurely, even if the maybe effective standard has been met, it can become difficult to run the subsequent clinical trials that you need to actually answer those critical open questions. And so there may be a role for clinicians and institutions to step in and say, we're actually going to constrain access to a drug, even though it has an emergency use authorization, so we can run those trials. And I think the last point I want to make is, in general, right, the best way to provide patients with access is through clinical trials that have diverse eligibility criteria and lots of open slots, right? That's the way that we can answer these questions about safety and effectiveness as quickly as possible, and as with as much fairness and accessibility as possible.
Thanks, Holly. This may be a dumb question, but can you give me a sense of what needs to happen for an EUA to actually terminate or finish? That would be good to understand.
Yeah, well, the first way that an EUA can terminate is the one that we all really are crossing our fingers for, which is that the pandemic ends, right? That the emergency ends. So in order to have an emergency use authorization, there has to both be a declared emergency, and the Department of Health and Human Services has to make a second determination that they're going to authorize FDA to use the EUA power that they have. So once those emergency declarations go away, then all EUAs that have not transitioned to traditional approval also go away. The second way that an emergency use authorization can be terminated is if the legal standard is no longer satisfied. So that's what we saw happen with hydroxychloroquine. Early on, maybe there was an argument that maybe there was an argument that the may be effective standard was satisfied, but as we learned more about hydroxychloroquine, it became clear that it was not effective, and then we had these safety considerations. So FDA then pulled that EUA back, revoked it. And then the third way that the EUA can end is that you continue doing research, and actually then you submit your traditional marketing application to FDA, and they decide that those legal standards are satisfied and you no longer need the EUA because you have traditional marketing approval.
Okay, thanks, Holly. Thanks for that overview. Really interesting and thorough. So I'm going to now turn to what the most important part of the presentation, which is the patient perspective. So Claudia, as it relates to data, it would be good. My experience is that patients are more than willing to share their personal data for the benefit of other patients and for the benefit of future patients. But that is very much linked, and the caveat to that is it's linked to a frustration of them not receiving any kind of feedback mechanism or feedback loop to understand what actually happened to their data and what it showed. So it'd be good to understand from your perspective. You speak to thousands of patients and patient groups every year. Understand whether that's something that you see and how it in particular applies to I guess this situation in COVID-19.
Thank you, Tom, and thank you, Dr. Joyner, for your openness and for your presentation. Yes, absolutely. Patients generally are motivated not only by the opportunity to benefit personally, but also the fact that their participation can impact the greater good. I think the frustration regarding feedback data is one that is pretty constant across different approaches. So it's not specific to this, and it's definitely a significant issue. But the expectations of patients can be different based on a number of factors. This includes their experience of participating in clinical trials or their understanding of the mechanisms for access to an investigational treatment. That is, a treatment that has not yet been approved by the FDA or other regulatory bodies. In a novel infectious disease treated in the acute setting with no established treatment protocols, we need to take into account that the patient population may not have an understanding of what it means to be an investigational treatment, and along those lines be unable to appreciate that this is an unproven treatment approach where even the safety data is still to be validated. In addition, let's just picture those patients for a moment. It was all over the news that there could be a shortage of ventilators. The messages from our administration and the typical sources for information in situations like this, the CDC and the World Health Organization, were frequently conflicting. It depended a lot on what news channel you heard in terms of whether you should be very worried or not. Some of them were reporting death rates by the day. So it was definitely a very frightening time. And patients must have been extremely frightened making these decisions while in isolation. There was no COVID-19 support group you could call for advice on how to handle this. And it's often, in the best of cases, difficult to get a second opinion in a hospital setting, particularly difficult, I think, when you have a novel disease that's not well understood. So if your doctor tells you about an investigational treatment, and the doctor may provide all the appropriate caveats, there are some factors that would probably indicate for a patient that there is a presumption of efficacy. It's reasonable to deduct that a treatment that received emergency use authorization because the regulators thought it was appropriate, right? This is an indication, a hint that there is some efficacy in there. In addition, there's publicly available information highlighting that this is a century-old approach that's been given to thousands of people, and those things help hint at efficacy. But most importantly, I just want everyone to consider that the responsibility of the individual patient is to make a decision on the risk benefit for himself or herself. And that is really what they will be trying to do under this very difficult circumstances. It is certainly the responsibility of the medical community, the investigators, researchers, and of the regulators to help protect patients so that any access issues would not interfere with clinical trials and that patients wouldn't be exploited in the process of generating data. I think that I commend the physicians and the investigators for trying to create access for something that they believe to be useful in a very frightening disease. But I think it is overall, from the patient perspective, dangerous and short-sighted, because we may never learn the real impact of this treatment and therefore not really understand who it is appropriate for and who it may really help.
Okay, thank you, Claudia, for that important patient perspective. Mike, we've got about 20 minutes left of this webinar, and I'm keen to get to audience questions at the moment, but you can see even within the panel that there's strong feelings about the expanded access programs. You only need to go on Twitter for 5 minutes to know that, so you'll be well aware of that. So I want to give you the opportunity to, I guess, respond to any of the comments the panelists have made so far.
I mean, they're all valid. This is the classic, blind man and the elephant story. And depending on your perspective, how you look at it and so forth, they're completely valid. And the question is, how do we get to the elephant, and how do we recognize the elephant sooner the next time, I think, as you talked about learnings, Tom. And I think the other thing too is that, I've been doing human studies literally since I was a human subject as a track athlete at the University of Arizona in the late 70s. And gave my first written informed consent was a mimeographed one-page sheet. But I thought about this, but I've never done a large trial like this or a large data set like this, not an infectious disease person. So I think one of the things that allowed this to happen it was my ignorance, frankly, because I didn't know how you could or couldn't do things. So I'm learning as much as anybody, and we were truly building this plane as we flew it. And I think just a whole bunch of things occurred to have this happen at the same time. And now that we've learned these things and have these perspectives that, as Claudia mentioned, Haley, Holly, and others mentioned, Tom, I think we're in a position to think about this in the future, and try to take advantage, for example, with what Dr. Belli said about the data analysis. Just the fact we have 105,000 people, so what? I mean, data, garbage in, garbage out. But within that data, we have some sort of pseudo-randomization and a number of experiments of nature that can be leveraged. And the other thing is we have rare patients. And one of the things that people need to recognize, as much as we want to do these large trials, large data sets, some very basic observations in rare patients have guided clinical medicine. For example, some people in the expanded access program are individuals with really, really rare forms of immune deficiencies, people that don't make antibodies, people that have something wrong with their B cells, things like that. And these individuals, some are showing remarkable responses, which give us some hint at least about the biological mechanisms. So I don't disagree with what anybody said at all. I think the one thing we've also learned in this is that whether you're doing a study in your lab, whether you're doing a study for pharma, you're doing a study with the government, and you're working within a large organization like my institution, bureaucracies typically run in series, where you go from one thing to the next. For some strange reason, this thing started to go in parallel, and it's really interesting to watch the world as things move in parallel, and to see people in bureaucracies struggle to catch up, and to think, wow, maybe we should have peeled off some of the academic sites and trialized it, versus starting from a brand new, here's the proposal, let's do this, set up a network, that sort of thing. And I think that's really important to think about. And I think the other thing people need to recognize is the role of individual institutions. Places like where I work, there's a pretty strict formulary, and a group can decide whether we're going to participate as an institution in a trial or a therapy or not. And certainly the large academic centers, and some did, agree to not enroll patients in the EAP and attempt to do their own work. So I think that's fine. And then finally, the other really interesting thing about this is by the time we identified a new area, a new hospital, a new city became sort of a hotspot. If you look at the time it would have taken to, even with the most efficient way you could organize a trial, by the time a trial would have been up and running and the patients began to enroll, typically the surge was gone there. So the half-life of an outbreak in a given place is, 2-3 weeks. So that was the other challenge as well. And I tell people to end this narrative, in this monologue here, is that people need to recognize what we're doing here. And I think, Claudia, you mentioned it. This is infectious disease. This is not a statin, cholesterol, heart attack trial that goes for years with a well-understood, stable disease with obvious endpoints and so forth. So I'll stop there, and we can go wherever you want to go next time.
Yeah, Mike, I appreciate that, and we sure appreciate your openness and coming on today. So that is, we thank you for that. Equally, you've been involved with Irwi and Cooper for enough time now to know that, we're all about action. So I think we'll probably set up a task force that will look to see what the learnings are quickly so that we can implement those, or at least, try to lobby for those changes to happen for the benefit of future patients. So I do have a number of questions coming in for the audience. I'm very keen to address some of those. If we don't get to them all, you have our commitment that we will get back to those questions with answers separately, because we do only have 15 minutes left. But I do want to try to address some of those. So the first one I'll address, which is how much larger is this expanded access program than what is common for expanded access programs? I've been involved in hundreds of expanded access programs over the years. Most of those run into the hundreds of patients, some run into the thousands, and the ones that run into the thousands will be for the therapies that are blockbuster type drugs for oncology, et cetera. Very rarely, if ever, do they run into the hundreds of thousands, and certainly, this is unique in its scale and magnitude. So that one's hopefully addressed. So Holly, first one to you then. So what do you think the FDA and/or BARDA could learn from the experience so that we can, stop directing that question towards just Mike?
Yes, I think that's a great point, right? So as I mentioned, the regulatory requirements are that expanded access not interfere with clinical development of a product. Now, FDA is not in a position to fund research, right? They're a regulatory agency. But what they could have done, and I don't presume to know what conversations were had or how any of this actually went in real time, right? But playing Monday morning quarterback, or whatever the expression would be when you're still in the middle of the game. I'm butchering this analogy here, but FDA could have at some point, as it's watching the number of patients, participating in this expanded access protocol rise, right, from 5,000 to 10,000 and all the way up, nearing 100,000, at some point step in and say, you know what, we think our regulatory standards are no longer being satisfied here, and we're worried that if we allow this to proceed, then it is going to interfere with clinical development of the product, right? And that could have potentially forced the hand of those who actually could have disseminated money to pay for trials, right? Like BARDA, for example. BARDA came up with money to pay for the expanded access protocol. I don't know what conversations were had with BARDA about, turning it into, or maybe I shouldn't say turning it into, but also running trials, side by side with the expanded access protocol. And Dr. Joyner mentioned the role of the clinical and translational science centers already, set up in these networks to run these studies, which could potentially have addressed some of the challenges raised about the hotspots moving around. I don't presume to suggest that running any of these trials would be easy, right? But certainly, in other countries, we've seen trials that have been run in ways that are producing results, randomized controlled trials that are producing results that are really answering important questions here about COVID and appropriate treatments. And for some reason, we've been having difficulty getting those things, running here in the US, as opposed to these kind of small studies, observational studies. There's been a lot written about avoiding pandemic exceptionalism, right? This idea that because we're in the midst of a pandemic and you have patients dying, that you should not be randomizing them, or you should be giving them, whatever you have access to, because otherwise they will die, right? And I think the argument that's been correctly pointed out is the way to address a pandemic is to get answers as quickly as possible, and just kind of throwing different treatment options at patients is not going to be the way to figure out what's going to to make them better, or what's going to make future patients who are also suffering from, you know, this pandemic disease better. So I'm veering away from your original question, but I do think the regulators had a role to step in here and say, we think our regulatory standards might not be satisfied anymore. And then federal funders also had an opportunity, I think, here that was probably a missed opportunity. We haven't talked, and I'd be interested in other panelists' perspectives about the fact that convalescent plasma is a unique product in that it's not being developed by a drug company. And that probably also influenced some of the challenges in getting trials up and running.
Sure. I think there are a number of factors, and I think that's definitely
that latter one's extremely germane, relevant. And even in some countries, they wonder why the FDA is regulating convalescent plasma at all, because they just see it as a kind of a variant of fresh frozen plasma. And in my clinical world as an anesthesiologist, we give buckets of the stuff.
Yeah.
So I have another question here, Claudia, for yourself, directed for you. Do you think that there are ways to channel patient engagement towards trials rather than towards expanded access?
Yes, it is challenging in areas where, again, the patient may not have had an opportunity to consider these trials or know about the opportunity. The first time they're hearing about this is in a hospital room where they are in isolation and they are very scared. The general level of information about the importance of participating in clinical trials is still significantly low, and we would love to have that dialogue be more prominent. And this is probably another missed opportunity, which is emphasizing the importance of participation in randomized clinical trials.
Yeah, and in fairness to industry, I mean, I can't think of an expanded access policy website that doesn't start with saying that randomized.
Tom, you're muted.
Can you hear me now? Okay, so I can't think of an expanded access policy website that doesn't start with the words, we prioritize randomized controlled clinical trials because that's the best way for patients to get broader access in the long term. So I think industry are trying to do their part there, but good to hear your views on how we can improve that, Claudia. The more questions are coming in. We're not going to be able to get to them all, but as I said, we will reach out after to those that submitted the questions. But Hayley, there's a few data ones here that maybe you could address. So the first one relates to it's a long question, but really it relates to the value that you can glean from, I guess, a single arm, non-controlled observational or expanded access program. And maybe some statistical methods you could employ to make that more valuable.
Yeah, and so one of the methods, and I think actually even you can chime in on this, Mike, I was looking at the preprint of the paper of the analysis, and it looks like you're using a matched control method, looking at patients in the EHR, which is an appropriate form of analysis to basically try to, they call these historical controls, where rather than actively in real time, you have a randomized trial and people are going along in real time, which obviously would introduce less bias, but it's certainly better to have some comparison that you can draw from. So that's one approach to basically making or trying to mimic a randomized controlled trial using retrospective data. Now, of course, EHR data has its own biases that can be introduced. Often it's people that are actually seeking out or used for insurance purposes. So it's a little different in terms of just somebody was assigned versus they actually went to a physician. But in general, it's just one of these things, as I mentioned earlier, you can also just look at patterns in the data. So as a biostatistician, whenever I get data, you look at it, you look for trends, you look for signals, and then you think about, okay, what are the biases that may have influenced this data set? What are the pros? What are the cons? What are the statements that I can make conservatively, given the trends I'm seeing, given how the data was collected, given the time frame, that all the conditions surrounding it, who the population is, how diverse that population is, who it was targeted for. So you just always look for trends and ask these questions that what is the bigger picture surrounding this data set? How generalizable is it?
You know, Dr. Beller, I'd like to just point one thing out, and this is, I'm going to share my screen if it's okay with you, Tom, to bring up my favorite paper. And this has nothing to do with convalescent plasma.
You're going a little bit off script. I'm not going to lie, Mike, but you carry on.
It's okay. But just it gets us to data, and it gets to us to what Claudia mentioned. And this was Secretary of Defense Robert Gates became aware that time to transport, if you just look here, average time to transport was only about 20% of trauma victims in the Middle Eastern wars were being offered definitive care within an hour. And it's a well-known principle of trauma care that you want people to get definitive care within an hour. It's called the golden hour, and it's especially effective in young people who are injured. So he started an initiative to make sure that that happened. And over a period of time, they got to around 65, 70% of people. And you can see that mortality, which was dropping, seemed to drop more quickly, leading to some sort of causal inferences. And so the question is who's going to do a randomized trial to have half the soldiers and Marines transported in less than an hour and half transported longer than an hour? So I think when you start thinking in terms of infectious disease and other things about time to treatment, what data can be extracted from a real world data set like that combat casualty care data, it raises additional issues. So while we all want to do as many randomized trials as possible, are all topics appropriate for randomized clinical trials? And again, is time to treatment for infectious disease, where over and over again, that's been shown to be critical, is that an appropriate thing to be trialized? I don't know. I'm just raising a question. And I think the other thing, Tom, that slide shows is that the importance of coordination. You know, all different arms of the U.S. Armed Services had different approaches to this problem, but Secretary Gates took it upon himself at the most senior leadership level of the DoD to get this fixed. And people had talked about, should the FDA have told BARDA this? And trust me, the CTSAs and the NIH is what struck me, again, as I thought about in series versus in parallel, is while they all communicated and had collegial relationships, there didn't seem to be a single site of federal coordination like there was when Secretary Gates did this for combat casualty care. So I think that's the other thing, Tom, when you think about the lessons learned, is to make sure that we have an overall kind of chief technocrat who sees the whole playing field, who can try to coordinate this, quote, the next time, unquote.
So Mike, I have one last question. We're running out of time fast, but I have one last question. It's appropriate to give you the last word on the question. So why is it different? Because you were quite clear on this point. Why is it different that pharma wasn't involved in this case? Why does that make an impact?
Well, even things like the EAU or EUA, BARDA holds the EUA. Pharma's got a whole collection of regulatory skill sets that permits them to apply for EUAs, just like Regeneron and Lilly are doing with the convalescent plasma products. So I think that you know, the blood banks and the blood collection systems are not-for-profit organizations. It's diffuse. I had no idea when I started how diffuse the blood banking system was. So there wasn't one single way to do this. And this is an unusual product in the sense that, again, when we started, we didn't even have the assays required to figure out what the antibodies levels were. So this is a really, really unusual product, obtained and quote manufactured in an unusual way. And if you look at where this plasma is coming from, it's a little bit like the brewing infrastructure in this country. You have hospitals with their own blood banks who could be seen as craft brewers. You've got regional breweries, and then you've got the big national ones like the Red Cross. And to try to coordinate all that was really pretty amazing. Whereas if you're dealing with you know, one or two pharma companies with a supply chain with sort of all that stuff cooking, you're ready to go.
Thanks, Mike. That's great. So I guess just to wrap up then, thank you so much to all of my panelists. Thanks to Arizona Law, Tara, yourself. Mike, we will regroup about what the next steps are for Cooper and Irby on this topic. I think there's a lot of work we can do for the learnings, and thank you so much for your presentation and your openness today. So So, and appreciate everybody from the audience who attended this hour. The event is co-sponsored by Cooper, the University of Arizona Health Law and Policy Program, and the American Society of Law, Medicine and Ethics as well. Tara mentioned at the start today that the next webinar is on the 4th of December, and Tara, more news to come on what the topic there is going to be. And we really are keen to get your feedback from today. So a survey will be sent out for all participants. We'd really be keen for you to give us feedback so we can improve for future webinars. And within that survey, there's continuing legal education points or systems that you guys might need. So please look at the survey. But yeah, thank you so much for everyone's time. That brings us just up to the hour. Mike, really appreciate everything.
Thank you for having me. I really appreciate the opportunity to visit with folks and get these perspectives and really learn a lot myself.
Great. Thanks a lot. Thanks, everybody. Have a nice weekend.
Take care.
Thank you. Bye.
Bye-bye.